Well, um, imagine paying thousands of dollars for a highly calibrated aesthetic injection.
Yeah, I mean, that is a serious investment.
Right. You sit in this pristine clinic, you're looking at a glossy menu of treatments, and the doctor maps out the exact millimeter where this filler is going to go.
Like a highly precise blueprint.
Exactly. You pay, you undergo the procedure, and you expect that filler to just, sit perfectly in place for the next year.
Because that's what the promotional materials say it will do.
Right. But what if, instead of staying put, the physical foundation beneath that injection is actively giving way?
Which is a pretty terrifying thought.
And worse, what if the mechanical stress of that collapsing foundation is causing your body's own cells to panic, sound a biological alarm, and literally eat that expensive filler from the inside out?
It sounds like a scenario from a sci-fi medical thriller.
It really does. Welcome to today's deep dive. I am so excited for this one.
Me too, because if you look at the stack of source material we are diving into today, this isn't sci-fi. It's a very real, very documented biomechanical phenomenon.
Our mission today is to explore a fascinating and honestly sometimes controversial intersection in modern medicine.
The intersection of aesthetic gynecology and urogynecology.
Exactly. We are looking at what happens when a structural pelvic floor issue, specifically a pelvic organ prolapse like a cystocele, impacts cosmetic procedures like G-spot amplification.
And our sources for this are incredibly diverse. We're essentially shifting the visual backdrop for today's deep dive from that glossy aesthetic clinic menu straight into a high-tech biomechanical stress testing lab.
We've got promotional clinic materials, anatomical dissections, dense biomechanical engineering theses like Milton Ma's viscoelastic models.
And even cellular research on vaginal fibroblasts.
It's quite the stack, and the goal is to connect the dots between the mechanical reality of a prolapsing vaginal wall and the longevity and positioning of a cosmetic filler bolus placed in that exact same tissue.
So whether you are a medical professional or maybe someone considering these procedures or just insanely curious about human biomechanics, this deep dive is going to completely change how you view the body's structural foundation.
But before we get to the collapsing foundation, we need to establish the baseline. We first have to define exactly where this anatomical real estate is.
Right, and what the cosmetic procedure actually entails.
So the G-spot. For a long time, this was treated almost like an urban legend. But our sources include some incredibly precise anatomical dissections by Ostrozensky.
Yes, Ostrozensky's work really moved this out of the realm of vague concepts and into hard anatomy. He identified the G-spot as an elongated structure on the supradorsal perineal membrane.
Okay, let's translate that directional terminology for anyone without an anatomy chart in front of them. Supradorsal means?
It sits at a very specific oblique angle, 35 degrees dorsal, or basically vaginalward, to the urethra.
That is wildly specific, 35 degrees.
It gets more precise. The poles of this structure are located specifically between 3 millimeters and 15 millimeters from the urethra.
So we are talking about a tiny, highly localized window.
Exactly, and that's where the G-shot or G-spot amplification comes into play.
Which clinics offer to basically increase sexual stimulation? What are they actually injecting in there?
Well, the doctor injects 1.5 to 2.5 milliliters of a bolus into the submucosal layer of that anterior vaginal wall.
Right into that 3 to 15 millimeter window?
Exactly. And the materials can be hyaluronic acid fillers like Juvederm or Nuvia Rose.
Or even autologous fat or synthetic materials like macroplastique, right?
Yeah. But the goal is always the same. Push the tissue vaginalward, creating a localized bulge to increase friction and stimulation.
And clinics claim these results last anywhere from 3 to 12 months.
Or up to 24 months for highly concentrated HA.
Okay, let's unpack this. It's essentially like placing a dermal filler to create a highly calibrated speed bump in a very specific anatomical pocket. But here's my question. What happens to that precise 35-degree speed bump if the road itself is sinking?
And that leads us directly into the pathology of the anterior vaginal wall, the cystocele.
Which is an anterior vaginal wall prolapse.
Right. It's where the weakened wall allows the bladder to basically sag into the vagina. And there are grades to this. Grade 1 is mild dropping. Grade 2 reaches the vaginal opening. And grade 3 actually bulges outside.
And the crucial anatomical overlap here is that the G-spot is located in the anterior vaginal wall.
Which is the exact same wall that collapses in a cystocele.
We need to talk about that MRI study by Spalinger from our sources.
Oh, the Valsalva maneuver study. Yes, that's a fascinating one.
Right. So Valsalva maneuver is basically when you bear down, like you were trying to lift something heavy or, having a bowel movement.
It spikes the pressure inside your abdomen.
Exactly. So what did Spalinger actually see on the MRI when a cystocele patient did that?
Well, when healthy tissue experiences that pressure, it pushes back. But in a cystocele, Spalinger found that the tissue experiences extreme shearing forces. The upper vagina moves downward toward the orifice.
Downward. Okay.
But the lower vagina moves ventrally, meaning it is pulled forward.
Oh, wow. So it's stretching in multiple conflicting directions all at once.
Exactly. The floor is literally shifting beneath the injection site.
So injecting a rigid bolus of filler here is like trying to pitch tent on a mudslide. The foundation is physically stretching and moving in the wrong directions.
Exactly. And if we look at Milton Ma's thesis on the viscoelastic model of prolapse tissue, we see exactly why.
Right, because prolapse tissue acts differently than healthy tissue, doesn't it?
Completely. Mom found that it has significantly lower tissue damping and a higher elastic response.
So it's basically acting like a dominant spring with a minuscule dashpot.
Yes, that's exactly the analogy he used.
The dashpot being like the hydraulic shock absorber inside a car suspension.
Right. Healthy tissue has that built-in shock absorption. Prolapse tissue doesn't.
So it just becomes highly compliant and distensible. It just stretches uncontrollably.
Exactly.
But wait, if the tissue is this distensible and constantly shifting ventrally under pressure, how could a filler possibly stay in that exact 3 to 15 millimeter pocket next to the urethra?
Mechanically, it can't. The tissue is so weak that it simply stretches around the bolus.
Or the entire wall just continues to sag.
Right. Entirely neutralizing that targeted bulging effect you're trying to create.
So the speed bump just gets swallowed by the mudslide.
Yeah, that's a perfect way to put it.
Here's where it gets really interesting. Because it's not just the gross mechanical movement threatening the filler.
No, we have to look at the microscopic cellular environment. The anterior wall is fundamentally altered.
Which brings us to the biochemical coupling paper in Frontiers.
Yes. Fibroblasts make up over 55% of the vaginal wall.
And in pelvic organ prolapse, that mechanical stretching we just talked about severely disrupts the cells.
Specifically, it disrupts the cytoskeletal actin filaments of these fibroblasts.
So the cell's internal scaffolding literally gets warped.
And the biochemical fallout from that is severe. These stressed fibroblasts start pumping out enzymes.
Right, matrix metalloproteinases, specifically MMP2
And MMP9.
Yeah.
Along with serine proteases like PRSS3.
Right, and these enzymes are literally designed to degrade the extracellular matrix.
Exactly. They break down collagen and elastin.
And to make it worse, TMP2, which usually inhibits these degrading enzymes, is downregulated in prolapse tissue.
So the body's natural regulatory system is offline. What's fascinating here is that we are placing hyaluronic acid or autologous fat into this exact environment.
Materials that are highly susceptible to enzymatic degradation.
Exactly. You're injecting them into a tissue microenvironment that is essentially hyperactive and chewing up and recycling its own matrix.
So what does this all mean for the patient? I mean, if a clinic brochure says a filler lasts 9 to 12 months, but that patient has a grade 2 cystocele, her anterior wall is basically flooded with these recycling enzymes. Doesn't that mean the bolus is going to degrade significantly faster?
Absolutely. The biochemical hostility of POP likely drastically reduces the longevity of the bolus.
So both the mechanical shifting and this biochemical enzyme soup are actively working against the filler.
Right, which brings us to the clinical outcomes for the patient's G-spot positioning and their overall sexual function.
And this ties back to Ostrozensky, right? He had diagnostic criteria for secondary dysfunction of the G-spot.
He did, and he explicitly lists a history of difficult vaginal birth or surgery of the anterior distal vaginal wall.
Because, as the sources confirm, childbirth and prolapse alter the normal anatomy and the neurovascular supply.
Yes. Because the prolapsed anterior wall lacks stiffness and its collagen to elastin ratios are completely disrupted, the filler bolus just cannot achieve its primary goal.
Right, it's supposed to push the G-spot structures closer to the vaginal lumen for friction, but the tissue just stretches around it.
Or the whole wall sags, yeah. If we connect this to the bigger picture, it really points out the blurring lines between aesthetic and reconstructive gynecology.
How so?
Well, medical societies stress that aesthetic procedures shouldn't be divorced from non-aesthetic medical realities.
Meaning you can't just ignore a foundational issue to give a cosmetic fix.
Right. Treating a patient with a grade 2 cystocele purely with a cosmetic G-shot ignores the foundational failure of the pelvic floor.
It really does. So let's recap this whole journey. We started with a highly specific aesthetic injection,
The G-shot placed with absolute millimeter precision.
and we dropped it into the mechanical reality of a sinking anterior vaginal wall, a cystocele.
Where we watched shifting mechanics and hostile degrading enzymes likely compromise both position and the lifespan of the bolus.
If you are listening and wondering why this matters to you, well, if you're ever navigating medical or cosmetic procedures, it highlights the importance of looking at the body as an interconnected system.
You really can't isolate these treatments.
No, you can't just build an addition on a house with a crumbling foundation. Structural health dictates aesthetic success.
But there is a really fascinating final question drawn from the sources.
Oh, right, the estrogen research.
Yeah. We know from the data that systemic hormonal replacement therapy, and specifically postoperative local estrogen, can decrease stiffness.
It also increases epithelial thickness and alters wound healing in the vaginal wall, right?
Exactly. So the provocative question is, could targeted, localized estrogen therapy be the necessary prerequisite to quiet down those degrading enzymes?
To basically prep the tissue, making these cosmetic fillers actually viable in aging or prolapsing tissues.
It's a fascinating frontier.
It really is something for you to ponder. Thank you for joining us on this deep dive. Until next time, keep questioning the foundation.